Assalamu alaikum. Now I would like to discuss about the gastroenterology, 10, the series of 10 page at a row. I like to discuss about this tracheoesophageal fistula with esophageal atresia. Before jumping into it, liver ultrasound is indicated for hepatomegaly in case of children if the liver age is more than 3.5 cm. In neonate, then it is considered as hepatomegaly, which can be suggestive of cholestasis and congestive heart failure. Okay, tracheoesophageal fistula. There is defective. What is defective? Division. So double D's, defective division of what? The foregut into esophagus and trachea. This is esophagus, this is trachea. So there is defective division of this. If esophagus and trachea is not divided properly, it is considered as tracheoesophageal fistula. Most commonly results in proximal esophageal pouch and fistula. Most commonly results in proximal esophageal pouch and fistula between distal trachea and esophagus. Clinical feature is coughing, choking, vomiting with feeding, and there is excessive oral secretion. Commonly a part of these vectoral syndrome, that means vertebral, anal, cardiac, tracheoesophageal, renal, and limb association. So it is commonly a part of vectoral, that means vertebral, anal, cardiac, tracheoesophageal, renal, and limb association. Diagnosis. Diagnosis is NG tube placement. NG tube placement, that means inability to place the enteric tube into the stomach. It is the, if you are unable to insert the NG tube into the stomach, then you will suspect that these may be a case of this. An X-ray enteric tube coiled in the proximal esophagus. Surgical correction should be done and vectoral screening should be done. That means vertebral, anal, cardiac, tracheoesophageal, renal, and limb. Echocardiography and renal ultrasound should be done. So renal problem, cardiac problem should be evaluated. In utero, the affected fetus is unable to swallow amniotic fluid. So you may get polyhydramnios on prenatal ultrasound. So you can diagnose these on prenatally. About 50% patient with tracheoesophageal fistula with esophageal atresia. Other congenital anomalies such as vectoral association may be found. Tracheoesophageal fistula with esophageal atresia less commonly associated with the Charge syndrome. This is trachea. This is esophagus. Trachea is divided into two parts, right or left bronchus. This is esophagus. There is esophageal atresia with distal fistula. This is distal fistula. There is isolated esophageal atresia, no connection, and there is H type tracheoesophageal fistula. So there may be esophageal atresia only, it may be 85% with distal fistula. In here there is esophageal atresia with proximal and distal fistula, and this is esophageal atresia with proximal fistula. Okay, and that is all about tracheoesophageal fistula with esophageal atresia. So one thing you have to remember to fight with the questions, that if you find a patient with this type of problem, go for NGs. If you cannot put NG into the stomach, then diagnosis done. This is tracheoesophageal fistula with esophageal atresia. Now congenital umbilical hernia, very common. There is incomplete closure of the abdominal muscle. Incomplete closure of the abdominal muscle. There is soft and non-tender and bulge at umbilicus. Soft non-tender bulge at umbilicus protrudes with increased intra-abdominal pressure. It protrudes with increased intra-abdominal pressure. It is typically reducible. You have to observe for spontaneous closure and elective surgery around age 5. Elective surgery around age 5. It is associated, it is commonly associated with hypothyroidism and Ehlers-Danlos syndrome, peak with Wiedemann and Down syndrome, but also occur frequently in normal newborns, but also occur. Small umbilical hernia actually close spontaneously. Spontaneous closure is less likely if it is large, more than 1.5 diameter, 1.5 centimeter diameter hernia. Surgery is recommended around age 5 for persistent hernia and or sooner if complication occur. Abdominal ultrasound is performed in older children or adults when acquired umbilical hernia is suspected. A congenital hernia is diagnosed. It is a clinical diagnosis. We know it's a clinical diagnosis. Immediate surgery is performed for gastroschisis and omphalocele. This is the two conditions where we need immediate surgery. An umbilical granuloma presence in newborn after umbilical cord has separated with moist, red, pedunculated, friable umbilical mass. Umbilical granuloma is treated with silver nitrate. Gastroschisis is an generally an defect. The combination of free-flowing intestine on the prenatal ultrasound, and elevated maternal serum alpha fetoprotein is highly sensitive for the diagnosis. Continuous exposure of the intestine to the anatomic fluid causes chronic inflammation and the edema, resulting in intestinal thickening. Nutrients are lost across the exposed bowel, which can result in fetal growth and restriction. In these conditions, fetal growth restriction due to nutrition loss happen due to exposed bowel. So exposed bowel, nutrition loss, fetal growth restriction, and oligohydramnios. Treatment is exposed bowel is covered with sterile saline solution and plastic wrap. In gastroschisis, it is not covered. So exposed bowel causes nutrition to loss and thus fetal growth restriction and oligohydramnios. So sterile saline dressing and plastic wrap immediately after delivery to minimize the insensible heat and fluid losses due to intestinal sequestration. An NG tube is placed to decompress the stomach. Antibiotics are administered. defect is repaired surgically. This is gastroschisis. Gastroschisis, herniation, uh, herniation of the abdominal content, just lateral to the umbilicus, herniation of the abdominal content lateral to the umbilicus, and it is not covered. And if herniation of the abdominal content through umbilicals and covered, and there is covering membrane, this is omphalocele. In gastroschisis, this is gastroschisis and omphalocele. Okay, now this is the difference of the gastroschisis and the omphalocele. In gastroschisis, there is paraumbilical herniation of the abdominal content, and this is gastroschisis, paraumbilical, lateral to the umbilicus, herniation of the abdominal content, and it is not covered, like this is not covered by the membrane, peritoneum or amnion, and it is not associated with any sort of anomaly. Like what are the anomalies? 13 Patau, 18 Edward, and there may be Beckwith Wiedemann syndrome, and there may be other cardiac GI, other cardiac GU, and neural tube abnormalities. Okay, now Beckwith Wiedemann syndrome. This is Beckwith-Wiedemann syndrome. There is dysregulation of the imprinted gene expression in chromosome 11p15. Dysregulation of the imprinted gene expression in chromosome 11p15. Physical examination is fetal macrosomia, rapid growth until late childhood. In Beckwith-Wiedemann, there is omphalocele or umbilical hernia, macroglossia, hemihyperplasia, and hypoglycemia. So, macroglossia, hemihyperplasia, hypoglycemia. Complication is Wilms tumor and hepatoblastoma. Complication is Wilms tumor and hepatoblastoma. And surveillance is serum alpha fetoprotein, abdominal and renal ultrasound. Serum alpha fetoprotein and abdominal and renal ultrasound. Most common. Most patients have sporadic alteration 11p15, which includes gene that encode insulin-like growth factor 2. Newborns must be monitored closely for hypoglycemia because fetal hyperinsulinemia can result in profoundly low blood glucose at birth. Newborn must be monitored closely for hypoglycemia because fetal hyperinsulinemia can result in profoundly low blood glucose at birth. Abdominal ultrasound and alpha fetoprotein level testing should occur every 3 months from birth to age 4, and renal ultrasound every 3 months to age 4 to 8. Pancreatic division. In pancreatic division, there is a congenital disorder that results in the presence of dorsal and ventral pancreatic duct failure. The presence results in presence of dorsal and ventral pancreatic duct to separate. It is rather combined. It should be separated, dorsal and ventral pancreatic duct. It can result in acute pancreatitis, annular pancreas that results in ring-like pancreas that encircles the duodenum. Annular pancreas, like anus, it encircles the duodenum. It can cause duodenal obstruction. So annular pancreas AD, annular encircles, causes duodenal to obstruct and causes vomiting, pain, early satiety. And in pancreatic division, failure to divide ventral and the dorsal pancreatic duct. Meconium ileus and intestinal obstruction due to inspissated meconium. An intestinal obstruction due to inspissated meconium. Prenatal ultrasound may show thick and dilated loops, dilated intestinal loop. Prune belly syndrome, defect in the abdominal musculature. Intestinal loops may be seen through the thin abdominal wall, causing prune appearance and covered by skin, not free floating. The Hirschsprung disease can present with abdominal distension, and biliary emesis, as well as delayed passage of meconium, Dilated loops of bowel would be seen on X-ray. Dilated loops of bowel can be seen on X-ray. In necrotizing enterocolitis typically presents with abdominal distension, bloody stool. Vital signs: instability in premature infant. The hallmark finding of X-ray is pneumatosis intestinalis. The hallmark finding on X-ray is pneumatosis intestinal, extravasation of gas in the damaged bowel valve. The pyloric stenosis most commonly presents age 3 to 5 with a postprandial projectile vomiting followed by hunger. This is hungry vomiter. An olive-shaped mass is sometimes palpable in the epigastric area. Then the next thing, infantile hypertrophic pyloric stenosis. It happens in firstborn baby, is firstborn boy with erythromycin and bottle feeding. It is projectile non-bilious emesis. There may be dehydration and olive-shaped abdominal mass. So in infantile hypertrophic pyloric stenosis, there is olive-shaped abdominal mass, forceful non-bilious emesis, first-born baby bottle feeding, first-born baby feeding, which is bottle feeding, and forceful non-bilious vomiting and olive-shaped mass. There is hypochloremic, hypokalemic, metabolic alkalosis, thickened pylorus on abdominal ultrasound. There may be IV rehydration and pyloromyotomy. There is olive-shaped abdominal mass, not always palpable, as retained gastric contents can obscure the mass. The abdomen will otherwise be soft and non-distended because minimal air passes the gastric outlet. IV rehydration, normalization of the electrolyte, and correction of the alveolusis prior to the surgery and have been shown to decrease the risk of postoperative apnea and improve all outcomes. If there is biliary emesis, how will you manage? Biliary emesis, stop feeding, angio decompression and IV fluid. And then you should do abdominal X-ray. Stop feeding, NG tube, IV fluid. Stop fluid, NG tube, IV fluid. The common scenario done in the ward. Doing abdominal X-ray. If there is free air, hematemesis, unstable vital signs, so perforation, you should do surgery. Free air, hematemesis, unstable vital signs, surgery should be done. If there is dilated loops of bowel, there may be increased rectal tone or normal rectal tone. If there is a phenomena, then do contrast enema. If there is microcolon, meconium ileus, if there is rectosigmoid transition zone, so HPD, Hirschsprung disease, should be thought. If NG tube is misplaced in the duodenum, upper GI series should be done. NG tube is displaced, or if there is normal abdominal X-ray, then upper GI series, ligament of Treach on the right side of the abdomen, malrotation. If you get double bubble sign on X-ray, diagnosis done. This is duodenal atresia. In duodenal atresia, it is associated with a Down syndrome, and you should do duodenostomy or duodenojejunostomy. Biliary emesis, unstable patient, unstable patient, that means free air. Emesis under the diaphragm, free air emesis under the diaphragm. Diagnosis done. Emergency surgery. With stable patient, do abdominal X-ray. In abdominal X-ray, you get free air. That means signs of perforation. Do go for surgery. If there is increase, if there is dilated loops of small bowel, and if there is increased rectal tone, or delayed passage of meconium, do contrast enema. In contrast enema, if there is microcolon meconium ileus, if there is rectosigmoid transition zone, it is Hirschsprung disease. In abdominal X-ray, if abdominal X-ray is normal, go for upper GI series. If there is ligament of Treach, right-sided ligament of Treach, malrotation is suspected. If double bubble sign, duodenal atresia should be thought. Double bubble sign, duodenal atresia should be thought. Hirschsprung disease and meconium ileus. Hirschsprung disease is the failure of the neural crest to migrate, and meconium ileus is obstruction by inspissated stool. Hirschsprung disease is failure of the neural crest to migrate, and meconium ileus is obstruction by inspissated stool. In Hirschsprung disease, level of obstruction is rectosigmoid, and meconium ileus is ileum. Rectal examination, increased tone, positive squat sign, expulsion of the gas and stool on a digital rectal examination, and in meconium ileus there is normal to negative squat sign. In meconium consistency it is normal, and meconium ileus this is inspissated. If you do imaging, X-ray or contrast enema. In X-ray, you get dilated loops of small bowel in both cases, but if you do contrast enema, microcolon in case of meconium ileus, and narrow sigmoid, rectosigmoid junction, narrow rectosigmoid junction in case of HPD. Hirschsprung disease is associated with Down syndrome and Meconium ileus is associated with cystic fibrosis. Meconium ileus is associated with cystic fibrosis. In Meconium ileus, there is hyperosmolar enema with surgical, and in HPD, usually we go for surgical resection of the aganglionic segment. So in Hirschsprung disease, congenital aganglionic megacolon, congenital aganglionic no ganglion and megacolon, failure of the neural crest migration to the distal colon, failure of the neural crest migration to the distal colon, neonates, delayed passage of the meconium, bilious emesis with or without enterocolitis, delayed passage of meconium, bilious vomiting and enterocolitis. In children or adolescent, chronic constipation and failure to thrive. Chronic constipation and failure to thrive. Distended abdomen, tight anal sphincter, absence of stool in the rectal valve. Distended abdomen, tight anal sphincter, absence of stool in the rectal valve. Forceful stool expansion on rectal examination. Forceful expulsion on the rectal examination. Diagnosis is rectal suction biopsy is the gold standard, and anorectal manometry, contrastinema, and adjunct. Management is surgical resection of the aganglionic segment. Surgical resection of the aganglionic segment. In Hirschsprung disease, congenital aganglionic megalon should be suspected in neonate with delayed passage of meconium because virtually full term full term infants pass to within 48 hours of birth, though passage of meconium does not exclude Hirschsprung disease, increased rectal tone, signs of intestinal obstruction, bilious emesis, abdominal distension, dilated bowel. Signs of obstruction will be present with both. Patient with long segment of affected colon classically presents in the newborn period, delayed passage of meconium. However, in patients with short aganglionic colonic segment, symptoms often develop in infancy. In early childhood include chronic refractory constipation and poor growth, failure to thrive. Contrast enema should be performed to determine the level of the obstruction and differentiate Hirschsprung disease from other etiology, meconium ileus. A transition zone between the dilated proximal colon, megacolon, and the narrow aganglionic sigmoid colon is characteristics of Hirschsprung disease. Diagnosis is confirmed by absent ganglia on suction biopsy. Absent ganglia on the suction biopsy. This is distended loops of small bowel, no air in the rectum. There is no air in the rectum. Mm, this is Hirschsprung. This is dilated aganglionic colon, abrupt transition, narrow sigmoid colon, narrow sigmoid colon. This is Hirschsprung disease. Markedly dilated bowel of the small bit of obstruction, and there is narrow transition zone in the rectum and the distal sigmoid colon. Nearly all healthy newborn pass meconium within 24 hours of birth. If unable to pass meconium within 24 hours of birth, think about any sort of problem. This is meconium ileus is the earliest Features of cystic fibrosis presence in the first couple of days of life with abdominal distension, failure to pass meconium. Imaging, there is dilated loops of small bowel, proximal to the obstruction with minimal or absent. They are minimal. There is minimal or absent here distally. Meconium ileus, there is dilated loops of the small bowel proximal to the obstruction. There is dilated loops of small bowel proximal to the obstruction. A soap bubble gas pattern may be present in the ileum due to mixing of the meconium with air. Air soap bubble contrast enema, water-soluble contrast enema revealing microcolon is a diagnostic of the meconium ileus. Water-soluble contrast enema. Water-soluble. This word is very important. Water-soluble contrast enema. Water-soluble contrast enema revealing microcolon. In here there is distal nares in rectosigmoid junction. This is narrowed. The markedly dilated. In Hirschsprung there is markedly dilated proximal to the obstruction and narrow sigmoid junction. In Hirschsprung disease it is a narrow rectosigmoid junction. But in meconium ileus, there is no narrow rectosigmoid junction. There is absence of air, or air in the distal colon and rectum. Absence of air in the distal colon and rectum. Contrast enema, microcolon. Microcolon. In meconium ileus, there is microcolon. Duodenal atresia is failure to recanalize, and presence with bilious vomiting in the first 2 days of life. Abdominal distension in the is absent because gas cannot pass in the duodenum. Extra reveals double bubble sign with no distal interstitial gas. Prenatal ultrasound shows polyhydramnios and includes discontinuing enteral feeds, nasal string, surgical repair. Preoperative. This is duodenal atresia, fluid in the proximal duodenum, fluid in the stomach. This is look like double button in double button. This is amniotic fluid pocket, amniotic fluid pocket. This is duodenal atresia. In contrast to duodenal atresia, jejunal and ileal atresia is not associated with chromosomal abnormality. Jejunal atresia is triple bubble sign. And malrotation. Malrotation may remain asymptomatic and cause acute and chronic symptoms. Midgut volvulus is intestinal rotation. Life-threatening complication usually present in neonate with acute bilious emesis and abdominal distension. However, intermittent volvulus can cause bilious vomiting, abdominal pain, which may manifest in irritability and inconsolability in children. Duodenal obstruction is caused by Ladd-band fibrous and peritoneal tissue that cross the duodenum and attach to the cecum. A high degree clinical suspicion is required because examination between episodes may be unremarkable. Diagnosis is confirmed using upper GI series, and the treatment is surgical to devoid the peritoneal bands and repositioning the bowel. Malrotation is associated with other congenital anomalies such as omphalocele diaphragmatic hernia and heterotaxis syndrome. The necrotizing enterocolitis, gut mucosal wall invasion by gas-producing bacteria. Gut mucosal wall invasion by gas-producing bacteria. There may be intestinal inflammation and necrosis. It may be due to prematurity, hypotension, congenital heart problem, very low birth weight, enteral feeding. And there is non-specific is apnea, there may be abdominal distension, biliary emesis. So there may be biliary emesis, abdominal distension, there may be hypothermia, blood is still biliary emesis. Abdominal distension, pneumatosis, intestinal here in the bowel wall. This is pneumatosis intestinalis, and free air under the diaphragm. Free air under the diaphragm is pneumoperitoneum. There may be sepsis, stricture, short bowel syndrome, and SIC. That means the IC sepsis. Short bowel syndrome, stricture in neck, there may be stricture, and DIC. These four things can happen as a complication of necrotizing enterocolitis. So prematurity, hypertension, congenital heart problem, very low birth weight, and enteral feeding. In this picture, there is pneumatosis intestinalis in red arrow. Air in the bowel wall. Air. This is air in the bowel wall. And portal venous air. In here there is portal venous air. There is air in the bowel wall. Portal venous air seen as branching area of lucency over the liver edge. Branching area of lucency near the liver edge due to gas producing bacteria and transmigration of the gas of the bowel wall of the mesenteric portal vein. Pneumatosis intestinal air in the bowel and the air in the portal venous air in the portal venous area. Discontinuation of the enteral feeding, NG decompression, blood culture, and empiric antibiotic and IV fluid replacement. Enteral feeding should be stopped. Blood culture, empiric antibiotic, NG decompression. Serial blood count and electrolyte, serial abdominal examination, imaging, indication of the surgery, bowel perforation, pneumoperitoneum, bowel perforation, pneumoperitoneum, clinical deterioration, vital sign instability, persistent acidosis, medical, bowel perforation, and clinical deterioration, vital sign instability, persistent acidosis, despite medical management. If there is happening to bowel necrosis, you do for surgery. First indication of surgery is bowel perforation and clinical deterioration. Immediate management of the neck includes bowel rest, discontinuation of the enteral feed, gastric decompression, parenteral nutrition, IV fluid, and empiric broad spectrum antibiotic. Blood culture should be ideally be obtained prior to administering antibiotic to help to guide the therapy. Response to therapy is closely via serial blood work, abdominal examination, and imaging. Surgical intervention laparotomy is reserved for patients with bowel perfusion free intraperitoneal air, clinical deterioration, vital sign instability, and for persistent acidosis despite medical management. And that's all about nearly 10 page of gastroenterology. Hope you enjoyed.